We are frequently asked to evaluate for lipomatous lesions, often not this large, but sometimes it will be a smaller lesion, and our job is frequently to identify whether it could be a lipoma or an atypical lipoma. And of course, liposarcoma is also a consideration there. When I say typical lipoma and liposarcoma, notice that I left out well-differentiated liposarcoma. And that's because atypical lipomas and well-differentiated liposarcomas are basically the same thing. However, it's best to use the term well-differentiated liposarcoma when it's a typical lesion in the retroperitoneum rather than in the extremities. In the extremities, it's best to use the term atypical lipoma. That's the guidelines of the WHO. And it has some surgical implications in that it could be the same surgery, but going into the retroperitoneum has a higher morbidity, and so you're doing surgery on a sarcoma rather than a typical lesion. Those also are much more likely to recur. So here we have a lesion, and the usual consideration is for nodular foci and for thickened septa or anything else. One of the things we do look for is these thickened septa, which are frequently muscle fibers if it's an intramuscular lipoma, but we're also looking for other things. In this case, we have on this T1 sequence a very well-defined focus of not fat tissue. We do have some other areas as well. They're fairly small. This is a vessel here. So if it wasn't for this lesion, I would say this looks like a simple lipoma. Couple of things. This lesion is a very strange looking thing. It's very bright and it has a fluid level. So it doesn't quite make sense for an atypical lipoma. But given the size is also a consideration. There's a little bit of dirty signal right here. Given the size, I'm not going to be able to say it's a simple lipoma. I could say it has characteristics of a simple lipoma, period. In this case, because of this other finding, I may be more concerned. However, this turned out to be a lipoma with fat necrosis. And there's not a lot you can do when you're faced with this. I don't think you can go out on a limb and say that it is a lipoma with fat necrosis. You can certainly suggest it in that it has such a strange look, fluid. It's basically a fluid lesion. But I wanted to show that not all lipomas appear simple. And now that I've shown a fake out, you can guess that this may be another. Here we have a lesion that has a fairly nice split fat sign. And split fat signs are typically associated with peripheral nerve sheath tumors. Here it is right here. It's splitting the fat. It has this little triangle at the top and at the bottom. And that is helpful. However, it's not diagnostic of a peripheral nerve sheath tumor. It says that it's in between muscle. That's pretty much it. If you follow it over here, it certainly is not the sciatic. That doesn't exclude a peripheral nerve sheath tumor, as they can occur on smaller little side branches. So if you see a nerve going into it and coming out of it, that's fairly specific for a peripheral nerve sheath tumor. However, if you don't see it, it could still be a peripheral nerve sheath tumor. Now let's take a look at some other features of this case. Does it have a target sign? It sort of has almost an irregular target sign, but the target sign is too irregular to be your typical target sign, and it's very irregular, especially over here on this image, and that is the stir image. So it almost looks, well, it does look necrotic rather than a typical target sign. And then if we were to look at the enhancing pattern, you would basically see the same thing. This isn't particularly helpful in differentiating them. It's more the signal and the irregularity. It's not good for a peripheral nerve sheath tumor, even though we have the split fat sign. What is also a possibility would be a malignant peripheral nerve sheath tumor. However, when you're looking at malignant peripheral nerve sheath tumors, the question becomes, can you tell the difference between a benign? And often they'll look in such a manner that you won't be confused, in that you won't bring up peripheral nerve sheath tumor, that is benign peripheral nerve sheath tumor, in your differential because it looks like a sarcoma. There's an exception, and the exception is when you have patients with neurofibromatosis. When you have those patients and they have multiple neurofibromas and you see one lesion and you're not quite sure, now you have yourself a differential of benign peripheral nerve sheath tumor and malignant. When you have a patient that doesn't have neurofibromatosis, usually you're not going to bring up peripheral nerve sheath tumor unless it looks very much like one. Also, most benign peripheral nerve sheath tumor occur in patients that do not have neurofibromatosis. It's not a diagnostic. What is diagnostic is the plexiform type of nerve sheath tumors that look like they follow the nerves all the way up and down. So this lesion turns out to be a synovial sarcoma, and showing you the split fat sign that is not diagnostic of, often suggestive of, but not diagnostic of a peripheral nerve sheath tumor. I may put that in the differential in this one, but it would be a malignant type. I would not suggest that this represents a benign peripheral nerve sheath tumor. This, on the other hand, benign peripheral nerve sheath tumor. First of all, we'll go ahead and look for that split fat sign here on this long axis T1 sequence. You can kind of see it right here. And more importantly would be, do we see a target sign? I do find the target sign very helpful. The problem is this is so small that if you don't see the target sign, it's a little bit difficult to say it's not there. There's a small focus right here. Now if I go to the contrast enhanced version of this, I almost see what maybe looks like a nerve going in and out of it. The reason I would include this in the differential is these lesions are common. And again, not only seen with neurofibromatosis, most of the time seen in a patient without neurofibromatosis. But when I see a small, well-defined lesion in most locations, in my differential is benign peripheral nerve sheath tumor, which is what this turned out to be. In this case, it turns out to be a schwannoma. I usually don't differentiate between schwannoma and neurofibroma. You can consider schwannoma maybe a little bit more likely when the target's larger. Another interesting variation or type of peripheral nerve sheath tumor is what's called an ancient schwannoma. And an ancient schwannoma is simply a nerve sheath tumor with a lot of degeneration. And these are also hard to differentiate from other lesions like sarcomas. In fact, I probably would never put that in the differential for this case. You have some irregular surrounding enhancement. You do have a fluid level. Could be seen in sarcomas, a little bit bright on the T1. Here it is on the post-contrast. Now, would you include that in a differential? I think that you're safe to just say a lesion like this. First of all the descriptors we discussed, but cannot exclude sarcoma. You don't have to put ancient schwannoma in the differential. Why is it important that you know about it? If it comes back in a biopsy that this is an ancient schwannoma, I think I would be okay with that, instead of saying that you didn't get adequate tissue, like I would in some other sarcomas that if they come back benign, I'm going to raise the flag and say you need to get more tissue. There are other things that you have to be aware of, or at least to think about when you're looking at a tumor case. And not all tumors are tumors. Not all masses are tumors. You can have other things. In this case, we have a well-defined lesion. This is the T1, kind of a strange pattern or signal. And then we go to the T2, kind of your typical heterogeneous increased T2 signal. So the first thing you're going to think about is something like a sarcoma. You also want to know the history, of course, in all of these cases. Down here I have the pre-fat suppressed T1. I usually don't spend a lot of time with this one, only when you can use it to try to determine if there's contrast enhancement. And otherwise, I don't pay a lot of attention to it. It's not like in body imaging where you sometimes need it. Over here I have the contrast sequence, and you can see there's some contrast enhancement here at the posterior aspect of this lesion. However, most of it is not enhancing